Dr. Harris is going to give us an update, and then we're going to have a discussion about the monoclonal antibodies again, as we have had an evolving situation from the last time.
Sure. Thank you very much. Thanks, Dr. Aurora. I appreciate it. Thanks to everyone for joining us again. We've been doing this now for a couple of months, and look forward to having you join us on Thursday afternoons for these talks. It's a great time for us to hear questions directly and try to give you the best information that we have. Let me give you just a quick update on the situation here in Alabama. We continue to have a really serious situation in our hospitals in Alabama. Our ICU capacity is beyond full. We have a net negative capacity. That is, we have more people in the state requiring critical care than we have actual critical care beds to take care of them. We've been in this situation now for well over a month, in fact, about 6 weeks. It's been a very, very difficult situation for our hospitals, for the doctors and nurses that are working to try to take care of all the Alabamians that are showing up in our hospitals. As we have talked about many times, it's unfortunate to say, but well over 85%, almost 90% of the COVID patients in Alabama hospitals are people who are not vaccinated. And there are maybe a handful of those for whom the vaccines don't work well or who may not be eligible. But by and large, almost all those cases are preventable or are largely preventable, as we know that people who are vaccinated rarely get hospitalized and virtually never die. So it's a tremendously disappointing situation that we continue to have such high numbers of patients. The total number of patients, inpatients in Alabama hospitals has declined a little bit. It's plateaued and declined just a little bit. I suppose we should take some comfort from that, from where we can, but we're still in a really, really serious situation. The hospitals are really, really overtaxed. And I hope it's not inappropriate for me to say, a lot of those numbers that you're seeing declining in the hospitals are because we continue to have double-digit deaths every single day. Some people leave the hospital not in the way that you would choose, unfortunately. So we are still in the midst of COVID. We are still having reports of thousands plural, of new cases reported to us each day. And it's just as difficult a situation as we have ever seen. We have seen a little bit of good news with people showing up to get vaccinated now. Fortunately, for really since beginning in late July, we've had many more people coming to get vaccinated than we were seeing in May and June and the early part of July. We right now are ahead of about 8 states in the country in terms of the numbers of people who have at least one vaccine. We're actually ahead of 3 states in the country in terms of being fully vaccinated. I won't pretend that that's a great place to be, but it's better than where we were. And we do appreciate people finally maybe getting the message and making a decision and coming out and getting vaccinated. We are going to talk today with our experts about monoclonal antibodies. And so I just want to, Dr. Aurora, if it's okay, I'll just give kind of a 1-minute update so that people understand the context of where we are. As you know, these monoclonal antibodies are terrific drugs that can be given to people who've either been exposed to COVID or who are actually infected with COVID and who are at high risk for getting really sick or getting into the hospital. They can reduce the risk of being hospitalized or getting severely ill really significantly. And so we try to give these products to people as soon as possible once we know they've either been exposed or they've been infected. Once someone's sick enough to be in the hospital, actually, we don't use these products anymore. We don't have evidence that they're effective once you're already in the hospital. So when people become infected or have an exposure, we have a real time crunch. We try to get those people the drug as soon as we possibly can. We have been using those drugs in Alabama since last November. Dr. Thrasher was literally the first person, I believe, in the state to use monoclonal antibodies, if I remember right. But over the past few weeks, there's been a real increased demand for them throughout the southeastern United States in particular. The feds have been allowing that product to be shipped free of charge to providers in the state. Doctors and hospitals and infusion centers and clinics could just order those products directly and treat the patients that they know about. But we had a change earlier this week, really without warning. Our federal partners let us know late Monday afternoon that they were going to stop allowing providers to directly order those products, but instead they wanted the state health department to be in charge of those orders. We they are requiring us, they have some reporting requirements. When physicians use those products, they need to report back to the feds, and that's the basis for the feds continuing to send us more product. And so we sort of, without warning, we're sort of put in charge of the distribution of this product. We have a method in place to do that. We're working very hard to do that. And starting this coming Monday, we'll have a new system in place that hopefully we can pick up distribution again pretty easily. But it's created quite a bit of turmoil. Many of you have heard about that. Some of the infusion locations that are used to ordering their own product are reporting that they're out of product or they're about to be out of product. You know, there are people who are on waiting lists to get drugs today or tomorrow or this weekend who have a time clock ticking because we want to get those drugs in as fast as possible. But unfortunately, this change in the distribution has created quite a bit of turmoil and uncertainty in the equation. So that's just a summary, Dr. Aurora, of what's been going on this week. We'll be glad to answer any questions.
I appreciate that update. I appreciate your time last night where you talked with providers across the state about this evolving situation. And I know many of our colleagues were extraordinarily frustrated as they are trying to serve their patients who have symptoms and could potentially fall without, getting the treatment. All right. So now, Dr. Thrasher, you want to go ahead and give us a little bit of an update on statewide situation?
Yeah, we're still in bad shape, as Dr. Harris said, with hospitalizations. The intensive care units are full. We're doing our best to keep people out of the hospital. The first thing we need to do is try to get everybody vaccinated. That's the first thing you do to prevent infection. If you get infection, however, with the virus, call your provider, and we've got mechanisms to get you these infusions. Now we have two. We have the original Lilly product called Bamlantam and the Regeneron product, which we've been using exclusively for the last few months. Let me put this in perspective. Alabama has always, since last year, been a leading force for monoclonal antibodies. We have given more doses per capita, I've been told by Eli Lilly, than any other state. And that's a good thing. We're a largely unvaccinated state, so we got more cases, okay? All right, the feds told us several months ago when the Delta got here, ramp it up and increase your infusion capacity, get more providers participating. That's exactly what MASA, Medical Association State of Alabama, Dr. Harris with a public health office, Dr. Sags at UAB, and all over the state, we were doing that. Put an example, this past June, Montgomery, we did 4 infusions for the entire month. July, we did 10. Did 100. We're on course right now to do over 2,000 just in Montgomery right now. These are patients that mostly will be kept out of the hospital. North of 70% of these people do not have to go to the hospital, and most will not die if treated early, okay? That's where we are, all right? We were doing fine. Regeneron came out with a new product that could be given what we call subcutaneously, under the skin. We ramped up, MASA ramped up many doctors' offices, rural offices across the state so that we could increase our infusion capacity. At the end of last year, I think we had about 100 infusion sites. Now we have over 228. I was told 2 weeks ago to, quote, slow down. We're treating too many people. Well, they talked to the wrong person about that. We're going to continue to ramp up. We're going to continue to treat patients. We're going to continue to recruit physicians who are opening their offices on Saturdays and nights to take care of our patients. Now, I've got to say that the entire state of Alabama has been working great together. MASA, Dr. Harris with Public Health, the Hospital Association, and all our congressional leaders. I want to just call out so many of these people we've reached out to and are helping us, from Senator Dan Roberts, Representative Charlotte Meadows, Representative David Faulkner, David Wheeler, Jenny Shaver, Arnold Mooney, Senator Jabbo Wagner, Senator Tuberville, Senator Shelby, Representative Mike Rogers' offices, Jerry Carl, Robert Adderhalt, Barry Moore, Alan Baker, Billy Beasley, and I know I'm forgetting somebody else, but I want to publicly thank these people for going to bat for us at fighting the feds. A lot of times I'm asked as a doctor, well, I've got this diagnosis. What do I need? But I feel great. I have a saying, if it ain't broke, don't try to fix it. Okay. Well, this system was not broke in Alabama. All right. We were told a couple of weeks ago that the 7, as I call them, the 7 southern red states were treating more people. Okay. And then the Fed said, well, we need to hold some back for some other states in case something happens. Well, they got a lot of negative feedback from our congressional delegation. And now they're saying all 50 states have to maybe hold back some. We were originally told we were going to get 70% of our allocation. That means 30% of people are not being treated and some of them will die. That is not acceptable. And I'm in private practice. I don't worry about stepping on toes from the government because, that's just the way I am. I'm 71 years old. I'm going to tell you the way I feel. This is not right what the federal government's doing. Alabama, we're on the same team. The hospitals, the doctors, our leaders, congressional leaders are doing what we need. And we're going to keep fighting this till we make sure that there's not 1 week goes on that we're going to give out supply. I understand, Dr. Runa, that we're already having trouble up in Huntsville and been told that we may not have some supply this weekend. You may want to comment on that.
Yeah, I did receive word from our hospital here, as well as, an urgent care clinic that is providing a good number of monoclonal treatments throughout this area. And they are expected to not have any more as of this upcoming Sunday, which puts us really in a bad predicament, waiting for the shipments, and going through this new process. So, what we have discussed, and obviously every hospital has some map on rationing of care that we don't ever want to reach. But in a sense, when you don't have enough supply and you have more demand, even with this monoclonal, we will be making decisions that are difficult decisions. And that is really unfortunate, because here we have been, telling the public, make sure to recognize your symptoms within this time period, and really it hurts us as providers to be in this situation. I mean, we want to be able to treat you, and we have our hands tied. So, all right, Dr. Stagg.
Dr. Just before we get to Mike, you brought a great point, the rationing. Basically, that we've been told we need to kind of ration care who gets the monoclonal. Well, we can't do that. I'm in Wyoming right now. I've got colleagues I've talked to today across the board in Idaho. Now they're rationing, but they're rationing in a different way. They're rationing to make the decisions, the doctors are, to who lives and who dies. They are full. They don't have capacity, and the entire state now is under what they call critical rationing protocol. Their protocols, example, this is just an example. A 30-year-old lady comes in, she may be pregnant. She needs an ICU bed. A 90-year-old lady has a stroke. She needs an ICU bed. The doctors are being asked to make decisions who lives and dies. We do not want that to ever happen in Alabama. And the way we can do this is make sure we have the supply that we need to treat these patients and keep them out of the hospital.
Absolutely. Thank you, Dr. Thrasher. Dr. Stagg.
Sure, thanks. It's good to be back with everybody. I want to amplify a couple points here. We talked, Dr. Harris just talked about the numbers in the state of cases, but also hospitalizations, and the number of hospitalizations are going down. I attribute a lot of that to the use of monoclonal antibody on a wider spread basis. Imagine the world as you're talking about, that if we happen to run out at different hospitals, we're going to see an uptick in hospitalizations, because there's no questions that the monoclonal antibodies keep people out of the hospital. There's a study that we're about to publish out of UAB on our experience back in the winter of this year, where we used it on over 750 people, and we compared it to the statewide numbers during that relatively same period. And what we saw was that hospitalizations were cut in half among the people who were treated with this, and that the deaths were cut by over 75%. Now you can say, well, wait a minute, that's not as great as I'd hoped. The thing that's really important here is that the folks back then who we were treating were substantially older as a group, over the age of 65, than the group at large who we were comparing to. So we all know that folks who are older get sicker with COVID. We know that they have more deaths. fortunately, 85+% of the folks over the age of 65 in Alabama have been vaccinated. They don't get to age 65 by being unwise. So they got the message and they protected themselves. We need the rest of the population to catch up. And it sounds like, on a positive note, based on Dr. Harris's report, we are catching up. So I think we are heading in the right direction. One thing that I will say that came up last night that I just want to say plainly, because most people listening already know the basics of the monoclonal antibody and how it works. And there are rules about administration. One of the cases that I heard about was a woman who, in her mid-40s, who's on chronic oxygen for underlying lung disease, had an exposure 3 days ago, tested positive yesterday. And one of the monoclonal antibody sites refused to infuse her because she was on oxygen. And technically, oxygen requirements are a contraindication, not approved by the EUA. That is not correct. If somebody's on chronic oxygen, home oxygen therapy, what you're looking for is a substantial change in oxygen requirement. Ironically, she's the precise type of person that you want to treat in the first day or two after an exposure and a positive test, because this has the best shot of bringing her infection under control and avoiding hospitalization and more significant disease. So I just wanted to make that point clear, because it is confusing. But again, this is it's good that we're having these kinds of discussions, because we are using this product in a very efficient and effective way for our state.
100%. And I think those kind of scenarios are playing out left and right. And luckily, colleagues are talking to each other, and we do have a protocol. Dr. Thrasher, Dr. Sag, y'all have helped us work on throughout the state. And we hope to put this on our website to help the providers kind of go through some of this algorithm that is very helpful to us. Okay, we have a few questions that have popped in. Dr. Harris, this one sounds like it may be for you. With little ones in school, why is the state not jumping in to stop the spread? How can we explain what is happening in a good way to prevent the spread in the school system?
Yeah, we certainly are doing the things we can think of to do. We have spent a great deal of time working with our Department of Education, but also with individual superintendents and with local school boards, trying to give them the very best guidance we can about how to protect people. The guidance has not really changed much, even since last year, with the addition of the fact that we want people to be vaccinated who are eligible to be vaccinated. That's the best way we can keep people from getting infected, but also the best way we can keep kids in school if they're exposed to a case, because then they don't have to go home as a close contact if they've been vaccinated. We support the universal masking of all people in schools. And when we use the word universal, we mean not just kids, but also adults, or also visitors, or anybody else who's coming into the school environment. We support universal masking of everyone in our K through 12 schools. And we support the continued distancing when it's feasible to do that. All the other hygiene issues and hand washing and all the things that we've been talking about all along. What's really changed from this year, from last year to this year, is we don't have a statewide mask mandate in place at this time. The governor's made it very clear that she thinks local school boards ought to be the ones making those decisions. Every community is a little bit different, but it doesn't change our recommendations or our guidance. We strongly believe that there ought to be universal masking in schools. And so we continue to try to hammer that message out with school officials. We're happy to talk to anybody who is willing to listen to us about that issue. And I think the best way we keep kids in school is to follow that guidance.
Yeah, I'm really glad, Dr. Harris, you said that, because literally yesterday I was called by a school board member of a local school board here in the Birmingham area, and they were having a vote on whether or not to extend their mask mandate for their school system. And they informed me that the quote state health department was not suggesting universal masking. And I said, no, you're not correct. The state health department is suggesting that all the superintendents consider this. And so I'm glad you confirmed that for me.
Yeah, that's written in black and white in our school toolkit, which we just reissued again at the beginning of this semester. That's I hope no one's trying to misrepresent us there. We absolutely support universal masking in schools, and I'll say it 10 more times before we get off the air, if that's okay.
Yeah, no, that is an important point. There are some school districts that are now considering a point where if the community percent positivity hits X number, that they would go mask optional. And your advice, it sounds like, is to continue to universally mask.
Yeah, and that's the best guidance we have from CDC right now as well. Certainly, at some point, we hope to reach a point in our society when we can not worry about that anymore. But we are not at that point, and we're not even near that point. I mean, our hospitals are completely filled up with cases, and anything we can do to limit disease transmission is something that we need to be doing.
Yeah, and Dr. Aurora, that's a good point, because some of the school boards are trying to get there. And I say to them, what's the hurry? Because the masks aren't hurting anyone. They're helping people by preventing things. Secondly, we know how volatile and quickly these conditions can change. It's much like the weather. So you're not going to walk outside your house without an umbrella if it could rain. And this epidemic can start raining again very quickly, as we learned from late June and into mid-July. So my suggestion to the school boards is get the mask ordinance in place. Continue it through the semester. We're likely to be dealing with this in fits and starts through the whole semester, then reassess as we go into our winter break. But I think to give the best protection for students and faculty alike, staff, is to have universal masking in place throughout the year. We've seen way too many educators who have died. There have been coaches of sporting teams who have died from COVID. And those are just losses that we can't continue to absorb. Can't absorb one, much less many more than that. So that would be my advice. Just keep it in place to the end of the semester, and then we can regroup.
And, go ahead. I was just going to say, I'm really proud of our colleagues, for using their voice and advocating with their years of training. I know Dr. Sag, you and Dr. Kimberlin and many doctors who are pediatricians taking care of children were part of a sign-on letter that just became more of a statewide effort with over 450, sign-ons at this point. And so it really is important to let the people who are the experts and the ones seeing this and treating this to help guide us and use that as a tool. Dr. Thrasher, you were going to say something?
Yes, I just got a text from one of our great senators who's been helping us a lot, Senator Roberts, and he was notified recently that one Jefferson County doctor group was promised the Regeneron infusion products be overnight today. It's not there. And we've talked about this, and I think Dr. Harris is helping. What we want to try to do is maybe let some of the hospitals who have the Lilly product on the shelves, which their shelf life has been expanded, make sure they'll use those to keep the Regeneron products going to the doctor's offices who cannot use the Lilly product usually in the office because they're giving it subcutaneously. So what I'm saying is already happening. We had a system that was going good. The feds get involved, red tape gets involved from the feds, and we're already seeing it. This is 2 counties now from Huntsville to Jefferson that are having problems. So if our congressional leaders, federal leaders are on the board, keep the heat up on the feds. The feds are not doing their job. Alabama is doing its job.
Yeah.
Let me add one other thing about the Lilly product, because there's a little confusion, because it was sort of pulled away for a little while things were sorted out with the Delta variant. The Lilly product will work against the current Delta variant. That's important to know. The combination, the 2 monoclonals in the Lilly product will work. It does not work against a subvariant called Delta Plus, and that's where I think there's a little confusion. To my knowledge, we don't see much Delta Plus in Alabama. It's mostly just pure Delta. The Lilly product doesn't work quite as well against a couple of other variants that we don't see. So I think if you have Lilly product, especially if it's a double antibody, then please use it, especially before it expires. It will work against Delta.
That is really good to know. Dr. Harris, you gave us a number for the amount of Delta cases right now? It was pretty much the vast majority of our cases.
Yeah, it's overwhelming majority. The CDC does surveillance testing. They do this genomic sequencing testing on isolates on a weekly basis. We send them specimens for that, and well over 90% of the specimens in Alabama are the Delta variant.
So that's really good information. Okay, so we've got another question. You've all mentioned criteria for receiving monoclonals. Can you please elaborate and go over that again?
Mike, you want to take that? And by the way, these are on the ADPH website, the MASA website, and the protocol that you mentioned that will be placed on the ADPH website. Right. Have all those criteria.
So I'm going from memory, so I might miss something, but it's basically age over 65, no matter what. It's BMI. The official thing says over 25. We've made it greater than 30 locally, but a BMI over 25, which is a lot of people in Alabama, especially. Anybody who has a chronic underlying condition such as hypertension, chronic kidney disease, those people who are immunocompromised in any form or fashion, the people who sickle cell disease. We unfortunately had a patient with sickle cell die this week who we gave infusion to, or tried to, and she, despite that, died of COVID. So those are it's pretty much any chronic condition, but keep in mind the BMI, because people who are especially over 30 with their BMI typically don't do well with COVID compared to people who are under 25. It doesn't matter too much if they're vaccinated or not. One thing we've been doing, and I'm not putting out as a rule, I'm just saying how we're triaging at UAB. If someone's been vaccinated, we're catching them early in the course of infection and they don't have much in the way of symptoms. That's when we're employing sub-Q as a treatment approach with these other criteria being met. If they're vaccinated, if they're immunocompromised, if they're struggling a little bit with symptoms, if we're worried about them, even if they're vaccinated, then we'll use an infusion, but it's a judgment call.
Well said, Mike. And basically I've said publicly, if you live in Alabama and you walk and talk and over the age of 12, you probably qualify. And what I'm getting by is that BMI. And I'm very aggressive on these patients because I believe in the product. It saves lives. So if you go to an urgent care, your doctor says you don't qualify, ask a question. Why do not qualify? I'm 230 pounds. Why do not qualify? So please ask for a second opinion if you think you might need the infusion.
Yeah, Dr. Thrasher, I might add, though, if they're not walking and talking, they may need the infusion even more, but that's a whole other.
And pregnancy is on that list, too. I know we've had plenty of pregnant patients lately not do well. All right, so we have another question. This is back to the schools about teachers. Are the teachers going to be vaccinated anytime soon, given that they were early on in the tiered approach to vaccinations? I guess it just comes down to we're still waiting on information, a meeting tomorrow, Dr. Harris, you want to address that with the FDA and ACIP?
Sure. Yeah, I guess as I understand that, when do teachers get booster shots? Maybe the question there. We should know more information tomorrow. The advisory group that advises the FDA is meeting tomorrow, and you can actually watch that meeting live streamed if you want to do that on the FDA's website. They'll discuss the evidence for booster shots. They're actually going to be discussing, my understanding is, only the possibility of booster shots for the Pfizer product. I don't believe they're fully ready to discuss the other two vaccines at this point. I know not the J&J, but I don't believe Moderna will be discussed tomorrow. So we could find out as early as tomorrow what the FDA is going to say about booster shots for the Pfizer vaccine, just that one. The process after that is, if this group recommends the FDA approve it, then the FDA will usually do that fairly promptly. And at that point, the actual public health people get involved with the advisory group to the CDC, which will again meet to talk about that. And then CDC will make its final recommendations, which is what we follow in public health. So that could happen as quickly as 2 or 3 or 4 days from now. We might have some information on booster shots for Pfizer. It could be that this group tomorrow could say, we don't think there's enough evidence yet to recommend boosters, or they could say, we just haven't decided, we're going to meet again later. So we really don't know how that's going to turn out. I do think ultimately, though, most everyone agrees booster shots are going to be needed for most vaccines. But until we really have good guidance on that, we're going to just have to wait before we make recommendations on it.
Dr. Roy, I agree with Dr. Harris. Dr. Sag is a world expert on vaccination. He probably knows more about vaccinations and boosters than everybody put together in Alabama. I had the privilege of picking his brain last Sunday night. And Mike, if you could just share a few of your own thoughts about the vaccinations. If somebody's had the virus, do they need a Pfizer, Moderna, 2 Modernas, 2 Pfizers, boosters, et cetera? Because there's so much misinformation on that.
Okay, so I'll try to be brief, but the bottom line is that there was heroic effort to get these vaccines approved in a short period of time. And like if those of you who played basketball, your coaches often said, be quick, but don't hurry. And that's kind of what happened. So we got the efficacy studies done impeccably well. We've got safety data that's provided as well. And that got us started. But what we lost in the short time period to get these vaccines approved was the usual type of activity that we had to follow the durability of the injections. We had to do that in real time, which is what we're doing. And that's why that's so confusing around boosters right now, because ordinarily if a vaccine, let's take shingles vaccine, when it was in development, those first studies were done, and then they did durability experiments and discovered, well, gee, you might need another injection at 6 months for some of these types of vaccines. We didn't have that luxury with the COVID vaccine. So that's the first point. The second point is that this infection, I think everybody would agree, is going to be with us for years to come. Now, hopefully not in an explosive type of surge or spike that we're going through right now. Hopefully this is the last of that. I certainly hope so. But we're going to be dealing with small outbreaks here and there. So I think all of us are going to be needing some sort of booster shot, as Dr. Harris said. And it's going to be different perhaps for each drug or each vaccine. Don't know that yet. But I will say this, that the Pfizer group, they have the data, as you just heard, and they're going to the FDA for discussion tomorrow. Moderna is a little bit further behind, but here's the key point. The Moderna product has more antigen in it than does the Pfizer product. And so that means that it not only might have a little bit better protection, if not in reality, theoretically, but with that higher, maybe up to 3-fold more antigen, it could be in a booster form, causing more side effects. And that's what they're working through right now. And that's why there's a delay on Moderna as we speak. So it could be that they say, okay, your initial shots are with the 3-fold higher, but your booster might just be the same amount of antigen as said Pfizer. And then finally, the question that I get every day, literally multiple times, is, well, if I got Pfizer, should I switch to Moderna? If I got J&J, should I go to an mRNA? The answer isn't known yet. We will probably know in 6 months, maybe, but we aren't going to know it in the next 6 weeks. So we're going to be left with sticking with what we know for now. And I think scientifically, if you ask me just independently, to me, the right thing scientifically would be to alternate, just like we do with flu shots. They have a different variant that we get exposed to every year based on what's happened in Australia over the last flu season during their winter. It gives you a broader breadth of response. The question, though, is safety. If we go from Moderna to Pfizer or vice versa, is it as safe? And we really need to know that before we recommend it. But conceptually, going from one to another product kind of makes some sense. I don't think anybody can recommend it now. I hope that makes some sense for folks.
Yeah, Mike, if someone has had a virus, unvaccinated, 30 days, do I get 2 Moderna, 2 Pfizer?
Yeah,
wait 90 days?
I meant to mention that. Yeah, thank you. So if somebody has, as we say in the South, sure enough COVID, right? And they're sick with it and they get through it. They've got immunity. They have immunity. Patients will ask, well, why do I need a vaccine? The reason is twofold. One is that the natural immunity may not give you the same breadth of coverage against variants. We don't know that 100% now. And secondly, we still don't know the durability of having an initial infection versus getting the vaccines. We're going to have more data on vaccines than we will on natural infection. We'll have that data sooner. But here's the cool part. If you've had an infection like I did back in March of 2020, I got the vaccine in December of 2020, and I measured my immunity, and it was through the roof, and it was against every variant, including going back to SARS-CoV-1, which was a 2003 outbreak of the original SARS epidemic. And so I think nobody wants to get COVID, but a silver lining to that is if you've had COVID and you've not been vaccinated, go ahead and get vaccinated. Wait, I'd say at least a month. I think 2 months, 3 months, still okay. But go ahead and get vaccinated. And that's going to be your best ticket towards longer lasting immunity and certainly a breadth of coverage.
Thanks, Mike. One last thing, Dr. Before I turn it back over to you. People say, well, I've had the virus. I can't get it again. I've personally treated now over 20 patients that had it twice. One patient who had it 3 times, and on the second time, he almost died, was on oxygen for several months. So it's not everlasting.
Yeah.
We've had thousands of reinfection patients that we've documented so far in Alabama who've had it at least twice, and many of them even more than twice, as you said.
The good news is many of them are going to get the vaccine these days. Anecdotally, so I feel like, they're certainly concerned. Okay, so let's finish up with this last question back to the monoclonals. Are we hearing many facilities reporting that they're running out? RMC reported they're out as well. So with Huntsville added, it seems to be a widespread issue. And the second question, should we expect COVID to become milder over time, or do we expect variants to worsen in severity?
I'll just jump in on the first part. I'll say we do have some facilities that are running low. When we had our meeting with HHS Monday afternoon, they told us at 4 p.m. that providers would no longer be allowed to order as of 5 p.m. the same day. So we had a 1 hour notice. And so these hospitals and clinics and physicians who were going to put their order in at 5 minutes after 5 suddenly found out there was no way for them to do that. So our pharmacy team has really worked hard with providers around the state to try to get them to access what product is available. And so there's undoubtedly going to be delays this week from people who were expecting to order Monday and get something Tuesday or Wednesday. That's not possible if they waited too late in the day to order. But by this coming week, we hope that a lot of those distribution issues are going to be worked out. We still don't know for sure what the total amount of drug will be available. We don't know if we're going to see cuts or are going to have limitations there. But hopefully, at least the process will be a lot more clear.
And I'll try to take the second part of the question. With the quoting Yogi Berra, predictions are always difficult, especially when they involve the future. With that as a caveat, I will say that I don't know, but looking at other viral infections of respiratory nature and that type of thing, what we've seen so far with coronavirus, this is going to be with us a long time. Variants will continue to emerge. And if you want to know the answer to why, it's simple. You got a virus that's replicating in a person billions of times a day, billions of times in one day. And when it does, it can make a mistake. It can have an error. And that error oftentimes kills the virus and it doesn't move on. But sometimes those errors, that simple point mutation, gives it a selective growth advantage. And in those situations, that's how a variant emerges. In the case of coronavirus, it's interesting. Unlike HIV that I know a lot about, coronavirus has a spell check. When it makes a mistake, it has an enzyme that can come through and correct it, but it's not foolproof. And so while it's less likely that you're going to see a variant emerge with coronavirus than, say, HIV, we will and we have and we will continue to see emerging variants because of those errors with just billions of copies being made a day. And it's like Darwin said in the 1840s to 1860s, survival of the fittest. So a virus that has a growth advantage, has an infectious advantage that it's more virulent, can outgrow the others. And that's exactly what we saw with Delta starting the 1st of July in Alabama. I think we can expect it. Our best protection are vaccines. You've heard it 100 times, 1,000,000 times. You're hearing it because it's true. And you can take that to the bank. For us to have our best protection as a state, as a society, as a country, as a world, as a global community, the vaccines are our salvation to get out of this. And the sooner everybody gets vaccinated, the better protection we'll have.
I think that's a wonderful way to end, to encourage people to go get the vaccine that we as Alabamians shouldn't take for granted. The United States have a summit going on, and many countries are trying to figure out how to get vaccines, and we have vaccines, and you can walk into any CVS, any Walgreens. It is extraordinarily easy now. It's not like back in December. And so please, we urge you, please get vaccinated. As you have heard with this monoclonal situation, we cannot promise treatments right now during these next few weeks. We're trying to sort it out. We are certainly on your side as patients who need help, but let us ask that of you. Please help us also. Thank you all for your time. Really appreciate it.
Bye, everybody.
Bye-bye.